audio sounds.
Thank you so much. We're live, guys. Hi. Sorry, everybody who's been watching. We had some
Oh, they saw
technical
that?
problems. No,
Okay, good.
nobody saw that. We hope. All right, so we're going to get started. Once again, my apologies at the late hour. I get very little help from my wonderful co-hosts. Anyways, just to let everybody know, this is not a substitute for therapy. This is informational and hopefully entertaining, but it doesn't constitute a therapeutic relationship. And if you're experiencing a mental health emergency of any type, call 911 or go to your local emergency room. So just to tell you who we are, let me announce that we have Dr. Jon Grayson, our wonderful co-host and author of the book, Freedom from Obsessive Compulsive Disorder. We have Mr. Zach Pacha, who is also a wonderful OCD therapist and now co-chair to the National Social Anxiety Center. I am Dr. Katy Manetta, and we're here today to talk about all things OCD. So, should we read the question that we were discussing earlier that came from one of our viewers?
I was trying to figure out should we jump into that, or do we want to jump into Valentina?
Oh yes, Valentina had a couple. Why don't we take care of Valentina, since she's one of our viewers right now? Valentina had a very interesting question for us. So I'm going to read Valentina's question, okay? So my grandmother has a mercury thermometer, and I worry that she might break it someday and contaminate our house. How can I tell if it's my OCD or if I should really steal it from her and give her a digital one? She thinks the one with mercury is far more precise. Now, if you remember, this is Valentina that has the problems with the asbestos. Just reminding you.
First off, I want to say this. I will never advocate for someone to steal. That's it.
No, I agree. Particularly from poor grandma. We don't want to be stealing from grandma.
Yeah, I mean, I think if you want, the thing to do is break it.
Yes, agreed.
Because then grandma doesn't have to worry about, she won't feel senile like somebody's stealing stuff. However, I'm not really suggesting that. I hate to be reassuring, Valentina, but mercury is actually relatively harmless. Like, if when I was a kid, unbelievably, they used to have these little puzzles. Instead of having a steel ball, and it had mercury in it. And so what you would always do is you'd break it open so you could play with the mercury. Because it turns out mercury to be dangerous. There's like two ways to make mercury dangerous. One, vaporize it and breathe it in. So I don't think you're going to be putting mercury on the stove and vaporizing it. Mercury mixed with other chemicals, so like eating seafood where the fish have mercury in them because it's not in the pure form, so it can get into you. Touching mercury is not going to quite do it. It's not like, oh my God, the entire house is poison. And presumably you're not going to dribble it down her throat, which, would be, it wouldn't actually kill her, but, wouldn't be good. So, I think everything in life is odds. So the odds of the house being contaminated in some way that would be horrifying. I'm sorry, it's not really. It makes it too OCD. So don't steal it and let her use it. And the worst that'll happen is someday it'll break in her mouth and maybe she'll swallow some mercury. But Zach, you're laughing. But that's
I know
not
you're serious though. Sorry.
It's not likely to be fatal. And it's also not likely to happen. We live with risk. You might be at more risk every day driving from your house to her house, of killing yourself in a car crash. So, yes, stealing it would be definitely giving into your OCD and, illegal, and make your poor little grandmother feel sick.
And
crazy.
As a general principle, what Jon is talking about here, right, is that when we think about these particular types of OCD triggers, we can't necessarily reassure ourselves that the worst will never happen, but we have to consider that there's a very low chance of the worst happening. And at the end of the day, all we have, as Jon said, are the odds. And so is there zero risk of this harmful outcome happening to grandma or happening to you if you happen to be in the environment? There's not a 0% chance, but it's a very low chance of this happening. And we have to proceed really based on our best guess, which is what, Valentina, I'm certain that you do every day of your life, which is that you hope you're going to make it to work safely in your car. You hope that you're not going to accidentally poison someone, et cetera, et cetera.
And in the case of Mercury, and again, I so hate being reassuring because I generally like people to live with risk. However, the quantity of mercury in a thermometer is not going to poison you. Mercury is really hard to absorb, so probably it's just going to be eliminated when she goes to the bathroom eventually. So, if she swallowed the mercury, she could contact poison control. They're not going to really worry too much about it. And it's not enough mercury to really do her damage. I think if you really want to do damage, she needs to be like drinking mercury on a daily basis. That might begin to start having some negative effects. So it's kind of like if you think about the Environmental Protection Agency, nothing is ever safe. They always talk about what's the lowest quantity of poison in our stuff that's okay. So it's how many parts per million. So it's just not enough poison for us to be concerned about. If you wanted, Valentina, and I'm sure you don't want this, I can suggest a whole bunch of other dangers arising from the thermometer that have nothing to do with the mercury. But it's like all of life. We survive by luck. Most of the time, bad things don't happen. And if mercury thermometers were as dangerous as you fear, certainly people my age would have numerous horror stories of people who, had horrible things happen to them from a mercury thermometer. Because I grew up with them. Digital didn't exist. So yeah, maybe it happens sometimes, but incredibly rare, and probably she'll be okay.
And all we have are the odds. So we just have to hope for the best and proceed based on
I would like to see a head-to-head test between the digital one and the old school thermometer, just to see which one is more accurate.
Oh, mercury
is more accurate.
Well, all I know is when my grandson is sick and we use the digital thermometer, and like if we happen to do it twice in a row, it comes up with a different number, and then it's like, oh my God, it's giving like a different number like 6 times. Like, which number is the right one? Let's try a different one to see if it, and it's kind of like
we call that the second opinion thermometer in our house. That's the second opinion.
Exactly. So it's kind of like we just give up on it. It's like, well, we hope this is close enough. So
we also
the mercury thermometer is like what it is. The only thing about a mercury thermometer, like it's just impossible to read it.
It is hard.
Yes, it is.
Yeah,
oh my gosh.
So it's more accurate. You just don't know what the heck it said.
Yeah.
But her grandmother but her grandmother, I'm impressed she can still read it. Her eyesight must be incredible.
Yeah. Well, we just saved. Maybe potentially we saved another thermometer from being stolen or broken. So.
I know that's right. We'll hear thank yous from all the thermometers out there. All right, so we have another question that was posed to us that was really sort of the inspiration for this meeting today. And so perhaps I should just take this in parts. That's my thought, is that I'm going to take this in parts so that we can sort of address each in due turn. The first question that our viewer asked, they were talking about the fact that they've seen 2 or 3 different therapists. It didn't really work, and they didn't even really tell her what ERP or OCD was, unfortunately. And then,
can I stop right there just to say something? I mean, those are huge. Just from the start, those are huge red flags.
Yeah.
obviously,
Yeah.
Right. If they
Zach
don't
is
see
right.
ERP, that's bad.
and spell it out.
Exactly.
I mean,
Exposure and
mind you,
responsiveness.
she actually mentioned one other minor problem that suggested they were no good, which was they also didn't identify her OCD.
Right.
Yeah.
So those two variables together, sadly, I mean, again, given without going through it that treatment's been around since '84, and both APAs agree with it, the IOCDF. It's easier to treat someone with OCD than change the behavior of mental health professionals. So,
That's true.
so those would be
Wow.
quick reasons to jump.
That's a good one.
And despite
It's
the fact that there are so many good resources out there, I still would argue that good OCD therapists are in the minority.
on the average data says it takes 17 years to find good treatment.
Oh,
Because
painful.
ERP, OCD is a lot of money, is a good money maker. So
Right.
first of all, I mean, at least they should say they're doing ERP. But a lot of people who make that claim and they don't really know what they're doing. So it's really very difficult for consumers. There's not a clearinghouse of who does good ERP.
That's right.
The foundation has a list of people, but the list doesn't vet them because they're not in the process of vetting. But at least they should say those words.
Yeah. OCD, ERP, right? They should say that. And if any of our viewers are interested, we actually have an earlier video, and I'll post this to the chat at some point, either now or in the future. We have a earlier video that we filmed that was all about this topic of sort of what to look for in a good OCD therapist, what kinds of things you're listening for. And so if anybody would find that helpful, that's one of our earlier YouTube videos. I think it's only on YouTube. Okay, so let's move on to the second part of this question. So the second part of this question, I thought this was a very interesting one and something that people might have questions, a lot of people might have questions about, is that this viewer was talking about a final exam that they have, which is coming up in 1 month. And it looks like this viewer finally found somebody who was sort of skilled in the treatment of OCD, but then had only completed the assessment phase of meeting with this new therapist, and now has a final exam coming up in a month, and is sort of wondering how long is treatment going to take? What should I expect? How fast can I turn this around? And that kind of question. And I was sort of thinking about this, and I was thinking probably all of us have had the example of somebody coming to us at the beginning of summer break and saying, I'm starting college in the fall, right? I've had this OCD that I know is bothering me, contamination, whatever it is. And what can we do by the time I start my college career in 2.5 months?
Oh, that's an easy answer.
What is it?
We can start treatment.
We can start treatment. Now, how much relief do you think somebody could experience between the start of treatment and when they start
There are
college?
many answers. Well, first of all, you know what? I can't guarantee. I mean,
No.
if it's a really simple I mean, first of all, are they on meds or not? Because they might need medication. So if they need medication, that's going to knock out 2 or 3 weeks. And that's if we guess the right medication first.
Right.
It's going to take me a few sessions to do an assessment. So I guess if we're really trying to do it before college, if everything's ideal and they want to see me every day, we might have some decent amount of relief. But they have to be really cooperative. They have to be okay with the goals of treatment. So generally, and I think it's I generally don't do treatment that intensively that quickly, but I'm going to say in 1 month that I'm not going to predict for a person. I'm going to say I think things can be good somewhere, like in somewhere between 6 weeks and 6 months. It's if it was a simple problem, you probably would have taken care of it by yourself.
It's true.
So,
How However, what I would say is this, is that, I've seen patients that have come in that have some sort of set of contamination fears, for example, that they have that relates to going to college and having to, share space with others. And we're able to really make a tremendous amount of progress with allowing family members and friends to really contaminate their home space if now this is if the patient is really willing to allow that uncertainty to exist. But if they dive in, if they really jump in and they're like, yes, I know I have to do this, and they really understand treatment, that treatment is about exposure to this uncertainty and tolerating the discomfort of exposure, then they dive in. And I've seen people make tremendous gains over the summer.
Definitely possible, but yeah, again, I can't guarantee it without seeing how they're going to respond. Are they going to cooperate at the level you say? And that's not a guarantee, but that's at least, or as they would say in science, necessary but not sufficient. They definitely need to start out that way, and but again, do they need to be on medication? What's the level of depression?
I got. Oh, go ahead. I have a person I worked with a few years ago where these conditions came up. They're like, I gotta go to school in the fall, and I'm like, okay, it's June, so we got this amount of time. Okay, what can we do? And I'm like, well, more or less, kind of like what John was saying. I can tell you we'll set it up and we can start, and then most likely we'll want to keep doing it when you get there. And I'll never forget, this is I was doing telehealth, and most of my clients I work with are in Iowa, so it's, I don't know if you noticed, it's a rural state. And so my client was talking about, she got on the call with me and she was like, oh my God, I just had the worst day ever. And I'm like, okay, what happened? Like, I had to move the garbage. I'm like, what does that mean? I mean, yeah, I know you're scared of contaminants, but like, what? Tell me more. What does it mean? It's like, well, I had to take this garbage and it'll go all the way down, and then I took the lid off. It spilled all over, and then there were maggots everywhere.
Oh.
And then she's like, so then I had to pick it all back up. I got maggots and stuff all over me, and I'm just sitting there. I'm like, uh huh. And then she's like, this has just been the absolute worst day ever. And I'm like, so let me get this straight. You just took a whole can of garbage all the way down, spilled it, got maggots on you, and you're still talking to me right now? And they're like, yeah. I'm like, how? You had me convinced that would have killed you.
Yeah.
But I did highlight the thing. I don't think you could pay people. You'd have to pay people a lot of money to do what you just did.
You're probably right.
Did she get better?
Yeah, I don't talk to her anymore.
You don't talk to her anymore, or she got better? Which one is this?
Ooh. I'm gonna go with she got better, and because she got better, she doesn't need to talk to me.
She doesn't have to talk to you anymore. There we go.
Yeah.
I was just thinking about, sort of these specific cases of emetophobia, right? Fear of vomiting. And, college can be a uniquely challenging time for that particular fear to come up. And so I've had plenty of clients who have that fear and sort of anticipate problems happening. And the truth is, when somebody does go to college and has a fear of vomiting that they're working on in treatment, when they do experience the first time that they have a roommate or a friend that vomits even on them or adjacent to them, we call this really a wonderful opportunity for exposure, right? That sometimes these happy occurrences just kind of throw themselves at us, and there it is. And we're able to really advance treatment very quickly with these sorts of exposures, assuming that the person allows themselves to sort of stay in it and doesn't run off to a decontamination shower.
True.
Yeah.
Or they throw up themselves and survive.
Or they throw up themselves. Yeah, sometimes illness can present a wonderful opportunity for exposure.
Have you ever noticed that folks with emetophobia, they're a very low probability vomiter?
Yes.
Well, outside of people who make themselves vomit, like most of us don't vomit most of the time.
This is true.
Yeah.
Those of us with children, though, it's like, you know, like from the ages of, I think, 0 to 7, those tend to be really heavy vomiting times.
Yes. But I don't know how much that's increased your vomiting.
No, it hasn't increased my vomiting.
I mean, so, you know, it's
But yeah, adults don't typically vomit very frequently, I think. All right, we're getting off track. Let's move back to our viewer's question. So I think we talked about this issue of time frames and sort of, you know, just to underscore here, it's so, you know, unique to the individual that trying to figure out what your time frame is in terms of treatment depends on willingness to embrace uncertainty. It depends on sort of the severity of your symptoms going in, any number of issues. But
I think there's a difficult acceptance issue within that question. You know, I understand the client is desperate in the sense that there's this big looming deadline coming up that I feel I must be better by. And what we're actually saying is, well, that might not be possible. I mean, just, you know, it's like, yeah, we can't guarantee that. We can't say, oh, if your therapist can't get you better in the next 3 weeks, you know, because I can't say, like, even if the therapist starts now, I don't know that you'll be better by then. I can raise the odds if we're doing intensive treatment, but intensive treatment's a fortune. You know, like insurance, you know, I'm going to have to deal with insurance if I want to see them every day and convince them that, you know, every day is reasonable. And you know, even then there's a copay, or if I don't, you know, and I don't take insurance. So every day makes it more likely. It raises the odds, but there's still a lot of other factors. Again, I don't know if this fellow's on medication, this woman, and if they need medication, there's a good possibility they do. Okay, that's going to take a couple of weeks to take effect. So,
you know, the other question is whether or not this viewer is asking us, am I able to go and take this exam, or am I able to go and take this exam comfortably, right? So there's, I think, a two-pronged question here. You know, when people ask questions like, you know, how long is it before I'm going to be able to work again or go to school again, or you know, do the dishes again if I'm afraid of touching soap or something like that. You know, the truth is that you could take an exam tomorrow, you could go to work tomorrow, and you could do the dishes tomorrow. So that's one sort of prong. The other sort of idea is this idea of like when you could do it comfortably. The comfortably part is what might take a while. But the can of doing these things is, I mean, it's not a matter of can, it's a matter of won't, right?
almost true.
Almost true. Correct me, Jon. I know you want to, and you will anyways.
I don't think of it as correcting you.
It's just adding a small sliver, right?
Yeah, it's adding a sliver, because I think technically it's a choice, but I think, you know, I think, and we've talked about this, I'm going to have to veer off to come back to the point.
We trust
I apologize, but because, you know, I don't know how to do anything simply. You know, I have tinnitus, and, you know, that's a constant loud ringing in my ears, which I don't notice until, you know, doing this. And as soon as I mention I have tinnitus, now I can hear the loud ringing. And my response to my tinnitus is, I don't care. But there are people who have tinnitus who get suicidal or get to go on disability. I don't know what I'm doing wrong because I don't get to go on disability. But they go on disability for it. And when you're working with them, part of the goal is a hyper awareness issue. I'm noticing fan at one. Part of the goal is convincing the person that we want to help you live with it. Now that's a hard sell initially because it's like, oh, you're just telling me I'm stuck. And it's like, no, you're not stuck. We have to try to explain to them in the way that they're not stuck. So I'll have a few things I will ask them. Maybe I've done them on the show. One is I say, let me ask you a question. Suppose you have your thing that you're noticing, and it's going to really slam into you for the next 5 minutes. It's going to be, relentlessly awful. And then in 5 minutes, for some magical reason, we know it's going to stop forever. And we know this, there's no question. How would you be? Wow, I'd be pretty good with it. I'd be okay with that. Say, okay, first of all, that's amazing, right? Because that first 5 minutes is the same whether it's 5 minutes or 5 hours. I know you want to say it's because only for 5 minutes, but here's the thing. I'm sure if I subject you to the worst physical torture I can think of, 5 seconds won't be tolerable, let alone 5 minutes. So there's something you do in your head that's making it better. A second question. Imagine one of your loved ones dies, and it's 2 or 3 weeks after their death. Will thoughts of them just pop in your head? Play along and say yes for me, Katy.
Yes, absolutely. Why do I have to say it?
Yeah. And might those thoughts be upsetting?
Yes.
And might it interfere with what you're doing?
Yes.
And would you call those thoughts, the way you're going to feel about this loved one 3 weeks after they're dead, would you and most people call that OCD?
No.
Okay. So the thing I want the person to think about is these 2 situations I described, the 5-minute situation and the how you're responding to a loss of a loved one are the same.
Does anyone ever go, yeah, but no, they're not?
Well, pretty much, except once. I had somebody the other day know the right answer. Everybody's sometimes people go, how? I usually wait for them. Sometimes people say yes, and I say, wait, you understand this? And they're going, well, not really. So the way they're the same is that in both cases, without realizing it, you've made a decision. In the case of death, you've decided, oh, well, that's normal, so that can be there. Right after 9/11, I asked people that about 9/11. Did it upset you? Was it interfering? Did it pop in your head on one? And this was 1 week afterwards. Everybody said it's not OCD, except for one guy in our support group. It's, I don't want to think about it. I see the bodies falling out of the sky and out of the building and this, and I don't want it in my head. For him, he didn't want to think about it. He said it was terrible. And of course, 1 week after 9/11, good luck not thinking about it. It would be like 1 week after everything shut down for COVID, not thinking about COVID. Like, you have to live in a little hole. In the 5-minute situation, the decision is, oh, for 5 minutes, I'll put up with this. I mean, it still sucks, but yeah, 5 minutes I can handle. But something's changed about the way they experience that thing. Tinnitus. When it hit me and I had it for about 12 hours, I wasn't actually concerned, but I called a doctor and I went, hey, I've got tinnitus. Is there anything medical I have to worry about? He went, no. Oh, okay, fine. I'm just going to hear ringing in my ears for the rest of my life. I made a decision. I don't care. So going back to this individual, I understand he doesn't have hyper awareness, but this individual is saying, I don't want to take the test if I have these thoughts in my head. She's feeling like that's not a possibility. She may not be at her best taking the test, absolutely. But she could decide to take the test. She can, because part of what we want to teach somebody isn't we're going to stop the thoughts. We want to teach them to cope with the thoughts. And part of it's like the thoughts are there, and again, when you keep reminding people they're going to have to live with uncertainty, are they questioning like, is there some disaster that's going to happen from not doing my rituals? And of course, what we're saying is, let's risk that disaster happening because the alternative is having a disastrous life due to OCD. Her accepting that idea as something she wants to learn is the first step. So first of all, I have no idea where she is in that acceptance path. That can take one session frequently, but it might take a few weeks to convince her that our goal is not to stop the thoughts. Our goal is to live with the risk of them. which goes back to the thing I was saying. It's like we're not trying to make the thoughts stop. We're trying to function if they're there or not. And one of the ways we want to take power from the thoughts is we want to learn to live with the possible consequences. Um, so although her main idea is probably not, I don't want these thoughts there, and that's the whole problem. That's kind of secondary to whatever she's actually scared of.
Right.
But it's kind of the same thing. It's like she's decided this is not doable when in fact it is doable, but I don't get to decide to do it by choice. Meaning, when I move from the denial, the fantasy of like this has to be impossible, or whatever, when I move from like I can't live with this to get to a point where I'm going to accept the other possibilities, that is a kind of mourning.
Yeah.
You know, it's the death of, you know, it's basically the death of control. I don't want this to be a possibility. Or go like, that's a possibility. You have to live with it in the same way. You're going to have to live with the possibility of being maimed, paralyzed, and disfigured in a car crash. You can't get in a car if you're not willing for that to happen. I mean, you don't want it to happen, but if it's not allowed to happen, you can't go in a car.
It's true.
You decide to take the risk.
You know,
So,
Jon, I want to point out that actually this exact issue comes up later in this viewer's question that she posed to us. One of the things she said was that she is obsessively thinking about people who gave her trauma or shock. And of course, she doesn't want to think about that, but she thinks about it in a way that's obsessive. And I
right.
think,
And of course, and I think I've said enough about the one thing, so I'll shut up. But of course, she's raised a double issue,
yeah,
which is, you know, I'm thinking. I mean, obviously, we don't know, but besides that, she doesn't want to think about that stuff. I'm guessing she doesn't want to deal with trauma. So, you know, if you've gone through trauma, you don't really have a choice.
right.
Because, you know, I think every trauma has two parts. And often therapists just pay attention to one. You know, I mean, as a woman, not me, you know that you could be raped. But, you know, if it hasn't happened to you, it's kind of like, yeah, it could happen. I'm not really worried about it. If it happens to you, I mean, right, treatment's going to focus correctly on all the horror that you had to go through. The treatment often misses this other critical thing because that feeling you have like it's not going to really happen, you never get to go back to that. You're going to live in a world where you can really be raped. And so what you're being asked of by everyone is, I want you to be happy in a world where you could get raped again. And that's a
This is back
hard
to that,
ask.
right? That death of control. Like this is,
So in the terms of not wanting to think about the trauma, part of what she may be thinking about is, you know, not wanting anything to happen again, which, you know, yes, she doesn't want it, but like going through trauma, I've learned anything can happen.
yes.
And so there's a lot to unpack there. So now this person is asking in 4 weeks, you know, not only does they have to accept that the various thoughts might be there, and you know, are they willing to learn to do that? You know, we can get them to do that in session one, and that is possible. That's something, you know, yes, I want to truly learn to live with the fact that this could be here. But now I have to help them over their problem. I have them cope with the trauma. I don't think I mean, it'd be nice if it's over in a month, but that's a big ask. I mean, you know, it's like the good news is they can be helped, but not necessarily on their timetable. And we
So
haven't even got to the part of the question that you wanted to talk about today, but go on.
well, let's also switch to the other thing that we were going to talk about today, which I think is a common thing in OCD that we see, and I'm going to probably encourage Zach to answer this one because I know you'll have a good answer for this. She also talks about this idea of having to think 3 times about things in order to kind of get past it. And so I thought we could kind of, in general, address this idea of counting rituals and how we manage them in treatment.
You ready? I have a great answer.
Okay, go for it.
We were depending on you.
Okay. Just stop it. That is not my serious answer. Hopefully people thought it was
Well,
slightly funny.
I was just gonna ask you to give a second best.
Ooh,
Often we have to accept it, because a lot of acceptance is living in the second best world. So,
That's
yeah,
right.
so I think your answer was great, but what's the second best answer?
yeah. It depends. Like you're like, okay, if anyone has a counting ritual, how do you address it? It depends on the person. Like, what is the function and what are you doing with it? And obviously,
Well,
the whole
let's just
part is
let me just review a couple items that can end up
okay.
being sort of a counting compulsion, right? So
Yeah,
counting while performing certain activities, repeating behaviors or repeating thoughts a special number of times,
this is
repeating
3.
behaviors at odd or even numbers of times, ensuring that an activity has been done a certain number of times or for a long enough duration, right? I'm going to do this for exactly 10 minutes or exactly 15 minutes. I've seen that so much. I had a client once that she had to exercise. It was like
She
7 minutes.
chose to exercise.
Yeah, sorry. She chose to exercise. Thank you, John. God, your corrections are just so helpful. So she chose to exercise for 7 minutes, 13 minutes, right? So, and it was such an interesting, so it would be like 7 minutes pause, 13 minutes pause, and there was
Right.
something about that felt very right. Let me see the number.
I guess. Well,
Counting
can I jump
objects
in yet?
too. Go jump in.
Yeah. So I mean, depending on what where they're willing to start. I mean, you figure out a way that they're willing to do to just completely interfere with it. Like I mean, when John, in your book, you talk a lot about like how do you make it as immersive as possible. That's always the way I try to go first. Usually, people aren't takers first for that, and we have to do more of a modified way. But if there's any way it could get to a person that can just interfere with all of their counting, that's where I want to definitely start.
Yeah, I agree. And one of the things John mentioned specifically in his book is this idea of, counting number of blinks or counting number of breaths and right. And that can have its own level of sort of complexity and induce this very maddening, the sense of, oh my gosh, I can't handle this anymore. If this, what if this goes on forever? Because constantly focusing on breathing or blinking is a really tough place to be. But this too, right? We interfere with that. And also we embrace the thought, maybe this will happen forever. Maybe this will continue on forever. Oh, so John's not listening to either one of us, Zach. John is actually
It's
responding to
okay.
our
We're all
I'm listening.
multitasking. Yeah, he is. We're
You were
multitasking.
being
We're
so
also
competent that I thought
yeah,
like, oh, they're doing that. I'm gonna just
exactly.
be here in the
I
chat for a
live for
second.
those little praise points from you, John. I live for those. Okay, so let's talk
What is it?
Valentina.
VR plus, VA
Well, no,
plus.
I mean, the thing that you were saying, the thing that's the one thing that you missed, I want to just go on your little correction
Thank
obsession.
you. Yep, go.
Um, the one problem in all the various forms of counting, there are some people who will do it just 3 times or do it whatever it is, but most of the time you can't get it right. I do it 3 times, but I messed it up on the second time, or the third time doesn't fit, so I got to start over and
I
do it
wasn't
again.
concentrating. I wasn't concentrating.
Yeah,
Right. And
that's
you
a
know
good
what? So
point.
now I'm gonna modify. I got to do my method 3 times in a row because I'm bound to get it right one of the 3 times, but maybe that doesn't feel right. So the ritual kind of blossoms, grows, and sends out a lot of branches. And so the idea, because as soon as I say I have to do something exactly right and I have to feel right about it, the game is over. So, obviously they're going to keep going over and over. And as Zach pointed out, I don't know why she's counting. I mean, I know she's likely to screw it up because that's the nature of obsessions. Whatever you want, the OCD is going to find a way to make you do more. That's why I sometimes I call it the OCD demon. It's like, just do this and it'll be everything okay. No, you know what? You need to do a bit more. But what is she risking? What is the fear that she's going to keep thinking about it? Is the fear that whatever? That's what she has to create. And
in there, Jon, I think we can also look to that explanation for why it is that, sort of why we should have the motivation to do exposure and response prevention work. And part of it is because if we can sort of look at the trajectory of the compulsion, what worked for us way back when we first started the compulsion is unlikely to continue to keep working. And usually what we end up seeing is that over months and years, the rituals become more time consuming, more complicated, less satisfying, less able to keep us calm. And so when we look at that trajectory, we can only extrapolate. Imagine if it's not just this bad as it is right here, but if it's 10 times worse if we give it another year before we do this, because it whatever it is, I promise it can get worse.
Sure. I mean, this poor woman that, wrote us, she's at the point where she's considered, well, no, not Valentina, this other woman. I'm going to get to we can get, but, the one who's responding to the question, she's becoming dysfunctional. She's thinking, I'm not going to take a test. She's getting overwhelming and depressed because, she probably has two reasons at least two reasons to be depressed. First of all, the more she lets OCD take control, the more life basically truly sucks.
Yeah.
So that's depressing. She likely needs to be on medication. I don't know if she's on the right one or not, but if she's on no medication, she's probably biologically depressed also. So she's kind of got a double dose. And, feeling hopeless and having your life seem difficult and watching everything disappear is truly overwhelming, and to cross that hump into risking doing all the stuff we're saying is terrifying. And I would love to address kind of specifically what's terrifying to her, but we don't know what it is because we're not talking. So we're speaking in generalities, but so it's not like it's easy, but again, 4 weeks might be hard.
That is a challenge. Let's address what Valentina is telling us. So, and I'm laughing.
Are you laughing because I already wrote it in?
Yes, I'm laughing at your response, Jon. No, it's a good response, although with a correction. I'm just joking.
Thank God.
So Valentina, if you recall, Valentina was the person who was very fearful about asbestos, right?
Mm-hmm.
And asbestos exposure. And we dedicated an episode to talking about Valentina's problem because certainly we've all heard cases of OCD that have this focus on fear of asbestos, fear of like what could befall me if I have contact with asbestos. And so Valentina says, my dad was helping someone to do some construction work in an old building and he washed his outfit in our washing machine. And I'm so angry that he didn't even pre-wash his clothes first. And so then she asks, how can I stop noticing these things like everyone else? And so we have an important part of this answer, which is, Valentina, you're not going to stop noticing them, at least not for a while. And we can't have that.
Why did you want to stop noticing? Like,
well,
because why would you want? Why would you want to stop noticing? Right, I get it, but if you do that, we pretty much have to kill you.
Oh yeah. No, but no, I'm sorry, you're being unfair.
I am? Okay.
Yeah. Because I think now I'm reading her mind, and I should just preface that in graduate school I flunked mind reading, so generally I ask questions, but I'm gonna test my skill.
All right.
She asked that she's mentioning how she's upset about what her dad did, and I think in the first part of her, even though it upsets her, the second part suggests that she's suspecting it's OCD. So she's kind of saying, maybe this is my OC problem, but you know what? Even if it's my OC problem, it really upsets me and it bothers me and I'm thinking about it, I can't get it out of my head and so on and so forth. Now, we could go back to the first thing we're saying, like, well, we're not really trying to get it out of your head. We're trying to have you live with it. But, I kind of went further. In answering her online, I said, well, Valentina, this is your OCD. Your ultimate goal is you're going to have to decide to live in dirty world.
Yes.
There are going to be a bunch of things that seem dirty to you. But, in terms of avoiding thinking, well, yeah, I agree, that's not possible. And so in this case, Valentina is incredibly lucky. Incredibly lucky. Because, if I have like a hyper awareness problem, it's always there. And although I want the person to pay attention to it, there's no, we're trying to teach them how to kind of do, it's very hard to give them something active to do. Because in general, treatment works best if I can give you an assignment that a dead person can't do. So, well, dead people, great at response prevention. They don't wash their hands at all, but they suck at exposure. They won't touch a shoe and put their fingers in their mouth. That's why I don't work with them.
They're great at quitting smoking too.
Yeah. So, yeah. So what I said to Valentina, which is the critical part, I don't want you to avoid thinking about it. I want you to be the cause of the violations. I need you. I don't need you. You need to make the house permanently dirty. You need to be relentlessly spreading it. So you're basically saying to yourself, I'd rather get better and take all these risks that apparently everyone else takes than live the way I'm living with OCD. Are you going to be safe? And the answer is probably, but maybe not. But the thing is that the world is actually contaminated enough that all of us survive by luck. For the most part, the bad things don't happen, but sometimes they do. Now, what the beauty of that is, your rituals are worthless. Whatever you're avoiding, I guarantee that I can find flaws in your rituals in ways that you are being subjected to a variety of poisons, germs, and all kinds of things, and there is nothing you can do. Literally nothing. You tell me a set of rituals and I will explain why it's good. You could say to somebody, listen, when clothes come in the house, I'm going to have a layer of plastic where I take my clothes off at the front door. I carry my dirty clothes on the plastic. Actually, I leave my dirty clothes outside. I walk on the plastic, take a shower, get clean, roll up the plastic and the clothes. Oh, I'm sending them to cleaners before I bring them back home to wash them in my machine. And if you do all that, there's still flaws in the ritual.
That's right. Because we need a little decontamination shower. And those are all important.
Well, first of all, in the air, this is really beautiful. Our homes are these incredible environments. They used to be like the outside because there wasn't much difference, but our home is a zillion micro environments. So in your stove and in your heating system live the same kind of microbes that live in hot air vents in the heated vents on the ocean floor. In your fridge, the kind of microbes that live in the Arctic live there. Your home is filled with all these things because there's always something that can live somewhere. And if you spray with Lysol, you will kill a bunch, but there are a bunch that are invulnerable to Lysol. So by spraying your house, you're allowing them to flourish, and you don't know if they're the good ones or bad ones. Now, It turns out, majority of these things that live and again, think of this, because this is super duper creepy. With every breath, you are breathing in tens of thousands of living creatures. You're not breathing dead air. You're breathing in thousands of creatures with every breath. That's like weird. And majority of them harmless. There's a bunch that actually you need. If they're not there, you're in deep trouble. And then there's a bunch of pathogenic ones that'll hurt you. And we survive them.
I want to be clear for just a moment for Valentina, if she's watching, that Jon's aim here is not to just be provocative for its own sake, not to be difficult or not to make you feel all icky because he's talking about this stuff. The things that he's talking about actually are important things to address during treatment with a good OCD therapist. These things will come up, and it's important for the person who has decided to engage in exposure and response prevention to consider all of these things, even if they're scary to consider. because that is part of exposure.
They're letting you know what a waste your rituals are. You can't actually protect yourself.
How
You know,
incomplete the
and you know
rituals
the
are.
majority of a whole bunch of microbes that are living on your skin, a bunch of them, their function is protecting you. They eat bad ones. They get rid of bad ones. So when you wash your hands repeatedly, not only are you washing off good microbes, you're making the skin raw and open and more likely to let in the bad ones. So, you know, everything is a delicate balance. Not, you know what? I'm wrong. I should not say that. It's a pretty robust balance that has a lot of room for error because otherwise we'd all be dead. I mean, that's simple. You're breathing in pathogenic things and your body generally defends against them. You know,
And,
so there are all
one of the
these
things
things.
I want to say, the good news is that for those of you who are fearful about these things, just listening to Jon and staying tuned in, it is an exposure because you're choosing to be here and do it. And
That
I
is a good
wanted to
point.
go back to something you said earlier.
And just to point out, just want to know, you're not getting rid of it if you walk around with a mask every moment.
That's right.
They're still all over they're still over your face. They're on your eyes. They're going in your ears. You have to take the mask off. You're breathing, you know, unless you don't eat, you're going to be breathing it in.
I believe we have the point, Jon, that there's no escaping.
There's no escape.
There's no escaping this stuff. Okay, I wanted to go back to something you said earlier because it's a very common question that we hear. I think all of us have heard a lot. This idea, you know, when people come into therapy and we start explaining the way ERP works, they say to, you know, people say, well, I don't understand why you're asking me to engage in this exposure activity when I experience this horror all day, right? Here's poor Valentina. And she's like, I didn't even choose to have it happen. And here's my dad, you know, being contaminated, coming in and putting his clothes into our washing machine and potentially contaminating the whole house with it. And so I want us to just really quickly address the difference between
To be very quick because I'm going to have to get off.
I know we do have to.
But here's the very quick. She is facing all day. She's not facing it all day. She's confronting it and trying to run away.
Yeah.
All day she doesn't.
Good
She's
point.
not. She's not working on allowing it in. She's working on trying to get it out. You know, we've said before. You know, acceptance is not like the Zen happy land of the world. Acceptance sucks.
Yeah.
Acceptance is you get to live in the second best world. The alternative is what you're living through now, Valentina, trying to have something that doesn't exist. In this world, you'll probably be okay and maybe not. I will probably be okay, but maybe not. Like, I live in that world where me and my loved ones can die at any time, let alone a gazillion other things. And all I can do is, like right now, and this might be sad to say, my entire world is Zach and Katy because they're here in the present. My wife, whom I love dearly, she's a great memory of past times I've had with her. She's a hope for future times, but she's not here right now. I think she's alive, but I don't know. I only get to have her when I'm with her. But if I have OCD, I don't even have that because I'm in OCD land. So why am I going to take this risk and live in that world to have the only thing I can have now? And now I'm going to get off to see a client.
I know.
Thank you very much.
Thank you, everybody. We'll be back in about a month. I appreciate everybody's patience. We'll work through our technical issues next time. I can almost assure you.
Should we do the after party?